already gated, so we're going out the veins here. We try to visualize everything on ice if we can. Looks like it's probably the left superior.
Yep, I think so.
This looks isolated. I don't see any signal there at all. So going further out here, Ava.
Yep, going further out.
Yeah, this looks okay to me. So obviously the thought, so he actually recurred fairly early after his ablation. So I was thinking that most likely his his veins are reconnected, but so far I haven't seen any signal.
I agree.
Looks like there's some signal here on the roof. So we have Volta here. So Volta is an AI guided mapping solution that helps us look for areas of dispersion. So that's what we're going to be looking for. So you can see Volta displayed as well. Don't see anything quite yet. So let's come a little bit lower. This is anterior. This is coming a little bit closer to the inferior vein. It looks like on ice. Again, I'm going to apologize to you folks who are not used to looking at ice, flip left, right, but this is the pen way. So this is something that you might actually have a common vein actually, but so it looks like that actually on ice. So that's further out it.
Yep, back out, same vein.
Yeah, actually there might be an inferior branch foot, so let's see here.
Okay.
So again, just continuing to come down. This is lower.
Yep.
So this is down near the floor. I'll come back and get more of that later in a sec, but I'd like to define this posterior aspect. So let's see here. Not much signal here. So that's the inferior vein there. So, and the left veins are isolated, so I don't see any evidence of signal there. I mean, again, there's a little bit of patchy stuff on the posterior wall, but let's start coming around and see what else we see here. This looks good too. Good in sense of that we have durable pulmonary vein isolation and potentially posterior wall isolation. Again, we haven't seen as much recurrence of atrial fibrillation with pulse field ablation, but it's not to say that it's perfect. All right, I'm starting to go towards the right veins. Right superior vein looks to be isolated too, so I'll just follow myself with ice. And yeah, there I am right there. Let's just check real quick. Everything looks good on intracardiac echo after. Just making sure. So no effusion after transeptal and beginning of mapping. Okay, and there we are. So yeah, that's just going. That's sort of more roof, it looks like. So let me come back around. There is a little bit of signal here on the roof, so you can see here, but it looks relatively organized. So we have not seen any Volta signals quite yet, but there is signal here, so certainly we can touch up the roof if needed. So, the strategy for patients who have persistent fib and or reduce.
Hold it there for a second.
Yeah, sorry, Hunter, I'll come back to you. I was right here. All right, so let's take a look here.
It's a little more anterior.
Yeah, I'll come back around too at some point. It's a little bit of a up, getting the sheath up into the groin. Yeah, it looks like we did have a little bit of dispersion there.
Yep.
Okay, sounds good. Let's keep defining the rest of the posterior wall. What's nice is the Abbott system has directionality with, you can see there, those blue tags to show dispersion. So that is helpful. That I don't have to manually tag, me meaning our colleagues in Abbott manually tag. Let me come back around posteriorly.
Yep.
Again, a little bit of a struggle with moving the sheath a little bit just because of the groin. But he's not an overly large man, but all right, so this all looks isolated as well. Yeah, we pretty much torched most of this. All right, so that's going towards the superior again.
Yep.
So sorry, I'm flailing a little bit here. So this is getting close to the os of the vein. Yeah, you can see it on ice there. So still no signal here as well. Let me get a little bit lower. The right inferior vein is always the one that's harder to reach with this system. Make sure I don't fall across. So again, no signal here posteriorly. Starting to push up the roof. You can see there on ice. Still don't see much here. see what my sheath looks like. Okay. All right, so again, starting to go towards that right vein. Again, still no signal here. Starting again, sort of a weird takeoff here. Let's come look a little lower. 395. Thanks, Paul. So we target ACT if this is more anterior. May as well come around and get some anterior stuff while we're here. This is down near the valve. So this is probably where we would start an anterior mitral line. So maybe tag D1, D2 as a mitral point. You can see that there on ice as well, with the possibility that we're going to have to do an anterior mitral line. Spin around anteriorly for me, please. Yeah, good. All right, let's keep... so I may as well define some of this anterior stuff while I'm here. It's probably going towards the appendage.
Yep, agree.
Yeah, you can see it on ice there. All right. So I'll define a little bit more of the ridge. Again, the veins are isolated. And normally what we'll do is either pace the ventricle or give some glycopyrrolate or potentially atropine when we deliver pulse field ablation for the veins. But these veins are all isolated, it appears. So no need to do that. All right, and then back around the anterior, please. So yeah, you can see the appendage there. So yeah, here we go. There's some signal here.
I'll hold it there for a second.
You got it.
Yep,
So,
getting those points.
So you can see pretty significant dispersion right here. So it looks like and this is AF Explorer 2. So we have different gradations of dispersion as opposed to the previous algorithm. So the newest and greatest from Volta. So you can see right here. All right, so this is interesting area, certainly an area of potentially targeting. Let's come around a little bit more anterior. Good. So got this here.
Likes it there too.
Yeah. So we'll get all this area as well. You have to be a little bit more patient, as is not one of my strong suits in terms of mapping or anything. But giving that a little bit extra time to make sure you define this is particularly helpful in trying to figure out your ablation strategy. So, these are the trickiest patients, veins, and now even posterior wall are isolated. So what do you actually do with them? So I feel like this is where AI mapping solutions like Volta can be super helpful. So yeah, let's come around here as well. So there's more dispersion here as well. So we'll define this. Got all this, guys?
Yep.
All right, let's keep coming around. Let's go in towards that right superior. Here's the roof here.
Yep.
Let's get this too. This looks visually abnormal to me just by looking at the signals, and Volta has confirmed that. It's a pretty significant dispersion. All basically looks like it's drawing me an anterior mitral line, which appears what I'm going to be doing for this patient. So we'll finish doing the map in fib. Obviously, you have to do the map in fib for this. And then we'll define an ablation strategy based on that, which appears that, again, vein and posterior wall are all kind of taken care of. But we're going to check more of the floor, as Jerome from Volta says. You have to do meticulous mapping, so I'm going to be doing that right now. I'll plug out to Jerome. All right, so this is starting to go a little bit, pushing out this superior.
Agreed.
I don't have to go too crazy pushing out further because it's clearly isolated. So veins are isolated. Unfortunately, I did a good job the first time. I did his first ablation. I can't blame this on someone else. And so while many times we hope when we get in here that the veins are reconnected because we know that these patients do best, many studies have already showed that patients who veins are isolated, their outcomes are quite poor in terms of recurrence. But we're hoping that with this, the patient will do better. I'll define this more, but yeah, clearly abnormalities here all throughout the anterior left atrium. So we'll take a look at this well. On his initially study, when I did it last year, I said that he only had about 10% scar in sinus. It's interesting. I'd be interested to see what his voltage looked like. I kind of already know that from his first procedure, but you can clearly see here areas of patchy abnormality, borderline scar, but beyond that, also dispersion. So particular areas that are of interest. Now, I did not map his initial procedure with Volta. I did it. He did present persistently, but I did the case basically anatomically and used voltage as a guide. As you can see here. So further going out the appendage. So that's there. We'll define this a little bit more. Now, the one thing we have to be somewhat careful of is that if we do an anterior mitral line, that we don't completely isolate the appendage, and if that's the case, you may need a watchman at some point or amulet in the future. All right, we'll come around anteriorly as well. Yep, this looks good. So I'll just have to be careful as I define those areas closer to the transeptal. But All right, we'll get all that as well. So just getting all this area here near the roof. Again, we've kind of already defined some of it, but I'll get a little bit more. So to watch that I don't fall across. Okay, so this is more septal. Again, going out that superior. So let me get this all here for you, Ava, as well.
Yep.
Again, we've tended to notice that there's a decent amount of areas of either termination or dispersion that are interesting. Right around here, like the anterior left atrium, sort of close to where you would do your transeptal. So certainly like A1, A2, A3, A4, those all look pretty abnormal to me. So, and Volta's confirming that. So, so we'll keep continuing to find the substrate in this case. So let's come down. So I don't empirically do mitral lines in patients. Some of my colleagues do. I've found that they end up not blocking. Now we might be able to do better with PFA. So we're going to do a FARAPulse guided ablation on this patient in just a little bit. You can see here as well. Again, lots of abnormality here. This whole anterior left atrium. Pretty interesting. And the other thing we want to make sure is that we had a wide enough circumferential ablation, but I think we did. It looks like from the first case. Yeah, let's keep seeing if I can come down. I usually go the other way, but let me just see while I'm here. All right, and then show me anteriorly. Yeah. Yeah, let's come around the other way. I always like potentially doing that, but I wanted to find some of this stuff near the transeptal. So we'll get all this stuff as well. This all looks good. Yeah, I mean, we were pretty wide. I mean, we'll take this all out when we do. Yeah, look at these signals. These are spanning the entire cycle length of the AFib cycle. So you can see that there. So, all right, that all looks good. To find a little bit more there. Again, pretty large atrium too, as you guys can see. Some areas are a little bit more organized, but certainly areas of abnormality as well. Now, if I knew he was going to come back with fib, I probably would have done this on the first ablation, but hindsight's 2020. So again, good there. All right, this looks good. All right, that looks pretty good. Let's try coming around posterior. I want to see what we got going on here. So show me posteriorly. All right, so this is near the floor.
Yep.
The left underneath the left inferior.
Yep.
So let's see here. Just show me straight posterior, please. Yeah.
Sure.
Yep. All right, so we'll define all this area here that has not yet been defined. Huge atrium though. So, but again, I don't see much here. So we had durable posterior wall isolation and pulmonary vein isolation with PFA from a year ago. So that's nice to see. Knock on wood, we haven't had to bring too many of these patients back since starting since 2024 with pulse field ablation, which is good news. You can imagine having to do this with RF would take a long time. And while I've only had a few fistulas in my career, they've been devastating. So obviously this has been super helpful in that regard. So yeah, we can put that up. But I think minus some of the roof stuff that we could potentially take care of, up top there, I don't see much, to be honest. Let's see if I can define this inferior vein for you.
Let's
see. I'd be pretty surprised if it's not isolated, given that everything else is. Let's see if I can see it. Yeah, I'm very close to it on ice, I can see. Let's see if I can come lower. And that's going out the superior portion of it. So there, that's the superior. Very weird takeoff for that thing. I'm glad I don't have to wire out this again. So this looks good. And let me come around and see. We'll get a little bit more floor stuff.
Okay.
Sorry, the catheter keeps whipping around. It's just the with the sheath being a little bit bigger. And you can see it started to go out one of the branches right there at the bottom, but
Right.
just trying to see if I can get
Looks
it.
like it wants to prolapse there.
Yeah, I see it as well. Again, it's isolated proximally, so I'm not super worried about it, but let me see what I can define lower as well. All right. Thanks,
Yeah, I
Ava.
think
So yeah, let me come a little
lower
lower here.
definition. Sure.
I want to
Tilt
see
you
all.
up.
Yeah, I want to see all this. This looks pretty healthy and looks pretty organized too. So very different looking signals than the ones we showed anteriorly. So let's keep coming here. We'll look to see where our border zone is. Like I like to preserve some of his left atrium if at all possible. So electrically, and this is starting to go towards that right inferior. You can see it on ice too, actually.
Right.
So close. Anyway, let me keep sliding around here because I want to get this geo.
Okay.
So we have all this geometry as well. I mean, it looks pretty well demarcated. I mean, I guess I might be able to touch up a little bit underneath that left inferior, but I don't see any abnormalities there. Voltage looks fine, and let's get this too while we're here. You can see me touching there, the spatula right on the HD grid right there. So that looks good too. So yeah, this is right at the os of the right inferior. So
yep, you can kind of turn you
right
this
there.
way.
Yeah, there it is. And it's isolated for sure. There. So that all looks sort of a nubbin of it. You can see it right there on ice. Yeah, see it spanning the right inferior right there. It's kind of pushed up against it. So I don't have to go too far at it since we're not going to have to wire out it, but just wanted to prove that it's isolated. Let's get some more of this floor stuff. So.
Okay.
So again, you have to spend more time, obviously, mapping these kinds of cases, but I think especially given that, let me go back to that area. So there was, very low amplitude signals here.
Yeah.
We might be able to clean up a little bit of the floor here with PFA. So it looks like we're going to do everything in flower today. So again, moving towards that right inferior. Good. Just make sure there's no signal down here. Yep, this all looks good. I don't see anything at all here, guys. So just that one area there that we defined. All right, and then let's come back around anterior. So, all right, so we'll get anterior roof here. Again, I only got a nubbin of the right inferior. You can see it starting to prolapse there, but that's okay. I know that it's isolated, so that's most important for this. All right, so that looks good too. And if I try to spend way too much time getting out that, I will likely fall back across my transeptal, which I don't feel like doing. Certainly not while being recorded. And so, all right, so here is starting to find some more of that portion as well. Again, I just have to, again, be careful here. We defined most of this already, but I'll get a little bit more of it. It's looking pretty good so far. Yeah, so you can see here clearly. And we'll come lower. That's down by the valve. Sorry about that.
It's okay.
Right, it's looking pretty good. Got this here. Yeah, I mean, it pretty much looks like it's drawing a very large anterior mitral lines through the anterior left atrium is the only areas that I can see. Now, one would argue you might just do that empirically anyway if you had no other options, but rather than look for triggers and put this gentleman on high dose isoproterenol, this was another alternative strategy. So what we'll do is we'll plan to ablate these Volta tags. Again, we'll have to anchor this as an anterior mitral line. And then if we don't terminate fib, then we will cardiovert him and induce and try to see if we can put him back into fib. And if we can't, I'm happy with that result. If we can, then I will potentially map again. I haven't mapped the right atrium, but that is also a potential consideration. But typically, this seems to be the area that we found the most of also in the restart trial, which this patient, would have been basically is a restart patient. So someone who chronically isolated recurrent fib. So, all right, spin me around. Show me the posterior portion.
Sure.
Okay, and that's all down near the valve. So, what do you guys think? Am I missing anything?
I think we're good. I think that right inferior was a tough spot to get to around that floor, but I agree with you. I think it's well defined and isolated.
Yeah,
Other than that,
no, I think
good.
you can see it's very small and has some branching on ice too. So you see
Yeah.
these two little branches, but I think we got at one of them. But I agree. I think veins and posterior wall isolated. I don't see anything there that needs to be targeted.
Agreed.
We could maybe touch up the floor underneath the left inferior, Hunter, but I think otherwise
there's like a little, like just the floor kind of adjacent to the CS might be good to do.
Yeah. You're talking about down there. Yeah.
So, if you just want to pull back.
Say that again, Hunter. So you're talking about
So if they rotate the map up a little bit, you can kind of see the bot. There's I'll go in there real quick.
Yeah, just show me where if there's anywhere I'm missing.
Hey, can you show the a floor view?
Oh, sure.
Yeah, like that. Yeah.
So you're talking about down.
Yeah, exactly. Yeah,
right here.
Yeah, just drag that around.
Sure.
I don't think there's going to be too much, but
doesn't look like it's just far field V. This is probably where one would draw a lateral mitral line. But I don't. I don't see much here at all. Yeah, that looks organized.
Maybe a little further back towards the septum.
Yeah. We can come back this way. This is all V. And this is all floor.
Mm-hmm.
Yeah. Then again, same thing. If you come down here, all down near the valve.
Yeah.
This would be, like it said, this would be where a lateral mitral line is. I don't see anything overly interesting. It seems like the anterior lateral.
I'm happy now.
Cool. Hunter's happy. I'm happy.
Would you want to define the lateral mitral isthmus just to make sure that there is conduction to the appendage laterally before we do the anterior line? I'm just not seeing much voltage through that area.
No, I see what you're saying, unfortunately. Like, we can look here. It may end up being that we do isolate the left atrial appendage, and then we'll talk to him about a Watchman in the future. But I agree with you. Unfortunately, I don't think there's any other choice. So there's not really much else to target, right, with veins, posterior wall, and he's very symptomatic in fib. So you're talking about right around here.
Yeah.
No, I agree. There's not much, but sometimes it's hard to tell in fib, so it's easier to tell in sinus. But I'm okay with delaying the appendage as long as we don't completely isolate it. But we'll check it for sure. All right, cool. Anything else, guys? Otherwise, we'll start ablating.
I think we're good.